The facial nerve can be divided into 6 segments: intracranial, meatal, labyrinthine, tympanic, mastoid, and extratemporal. The motor part of the facial nerve arises from the facial nerve nucleus in the pons, while the sensory and parasympathetic parts arise from the nervus intermedius. These exit the brainstem at the cerebellopontine angle, where they are enveloped in pia mater, and bathed in CSF. Here, they join together and traverse the posterior cranial fossa, before entering the petrous temporal bone via the internal auditory meatus. Both the facial and acoustic nerves enter the temporal bone at this site, with the facial nerve located superior to the acoustic nerve. The nerve then runs a tortuous course through the facial, or fallopian canal. This is sometimes divided into labyrinthine, tympanic, and mastoid segments. Within the labyrinthine segment, the nerve forms a bend, known as the genu of the facial nerve. This contains the geniculate ganglion, which contains sensory nerve bodies. The first branch of the facial nerve, the greater superficial petrosal nerve, arises from the geniculate ganglion. This runs through the pterygoid canal and synapses at the pterygopalatine ganglion. Postsynaptic fibers supply the lacrimal gland. The greater superficial petrosal nerve also provides parasympathetic innervation to the sinuses and nasal cavity. The external petrosal nerve is a second branch which is occasionally present, and provides sympathetic innervation to the middle meningeal artery. The lesser petrosal nerve is the third branch, extending from the geniculate ganglion. This carries parasympathetic fibers associated with the glossopharyngeal nerve to the parotid gland. The facial nerve continues through the tympanic cavity, medial to the incus. It then runs downward as the mastoid segment. In the temporal part of the facial canal, the nerve gives rise to the nerve stapedius, which innervates the stapes muscle of the inner ear, and the chorda tympani. The chorda tympani supplies taste fibers to the anterior 2/3 of the tongue, and also synapses with the submandibular ganglion, supplying the sublingual and submandibular glands. After emerging from the stylomastoid foramen, the facial nerve gives rise to motor branches to the posterior belly of digastric, stylohyoid, and the superior auricular, posterior auricular, and accipitalis muscles. The facial nerve then passes through the parotid gland, splitting into 5 branches, which innervate the muscles of the face. These are the temporal, zygomatic, buccal, marginal mandibular, and cervical.
Many different conditions can result in facial nerve weakness. These include infections, inflammation, trauma, tumors, and some congenital disorders. From a trauma perspective, of all the cranial nerves, the facial nerve is the most susceptible to injury. The nerve travels a complex course through the fallopian canal of the temporal bone, confined to a bony canal that is in some places not much bigger than the nerve itself. The nerve is therefore very susceptible to compression following swelling within the canal. Intracranially, temporal bone fracture following blunt trauma is by far the most common cause of traumatic facial paralysis. Motor vehicle collisions are a common mechanism of injury, followed by assaults and falls. These fractures are usually classified according to their orientation along the petrous bone. They can therefore be longitudinal, transverse, or oblique. Longitudinal fractures are the most common, seen in about 70 to 80% of cases. Nerve injury is most common following transverse fractures. However, injury can occur in about 1/4 of longitudinal fractures. Blunt trauma to the face is a rare cause of extracranial paralysis. This can be delineated from temporal bone fracture because it often involves only 1 or 2 branches of the nerve. Penetrating injuries, such as lacerations and stab wounds, generally result in an injury to the nerve distal to the stylomastoid foramen. In the adult, the nerve is protected by the mastoid, tympanic ring, and mandibular ramus. However, in children younger than 2 years it is relatively superficial. High-energy penetrating injuries here can also result in intracranial injury. Iatrogenic injury during otologic or parotid surgery, and injury caused by birth trauma can also occur. These represent a small but important group of injuries.